A warm hello to everyone on our social media platforms. We are so very excited to get together with you for this month's Sweet Talk with Us, the Sugar Queens. I am Dr. Eden Miller, an osteopathic board certified family practitioner, diabetologist, and obesity medicine specialist in Bend, Oregon. Queen Jen.
Hi, everybody. Jen Goldman. I'm a professor at Massachusetts College of Pharmacy in Boston, Massachusetts, and I direct the cardiometabolic services at Well Life Medical in Peabody. That's where I take my students and residents and fellows on rotation.
Queen Bee DeVita.
And I'm DeVita Kruger. I'm a certified nurse practitioner in Detroit, Michigan at Henry Ford Health Systems.
Oh, thank you, ladies. It is always a pleasure. I'm so glad to see us all three here around the holiday season. We're looking so festive. But guess what? For the next 30 minutes, our social media event will be on preventing DKA and hospitalizations through ketone testing. We'll even talk about the future of ketone sensing. You know, we have a feeling you may be in for a very big surprise as we discuss this kind of huge clinical gap. Okay, so let's get going. We'd like to have you start about thinking about DKA. This is kind of an awareness, get us all warmed up. We want you to think if this statement is true or false. DKA, which is diabetic ketoacidosis, is a leading cause of death among children and adults with type 1 diabetes. Please feel free to put your answer in the chat. We want to see you. We want to feel where you guys are at on this. We want to create some awareness. So place that in the chat so we can kind of get that creative juices going. And so one of the things that's kind of very shocking about this is the correct answer is true. It's true that this is the leading cause of death. And you know, the annual prevalence of DKA in those with established disease is varied. Adults have about a 3 to 10% risk, and youths have about a 1 to 10% risk. And the risk and incidence of DKA and type 1 diabetes and those hidden events that are never reported necessarily. We only hear about it when they're hospitalized, right? And what just so burdens my heart is that DKA is the leading cause of mortality for children and young adults and middle-aged persons as well. So let's talk a little bit about the definition of DKA, and we're going to just dive into this as queens because DKA is really that pathophysiology of ketosis as a result of beta hydroxybutyrate or acetone acetoacetate. And it's really from the breakdown of fat because the body on the cellular level is starving and there's this relative inefficiency or deficiency in insulin given the current metabolic state. And so why is it that the risk of DKA is increased in those from type 1 diabetes? So we want you to think about that, okay? We're getting going. We're talking about DKA today. We're talking about how it has that high mortality rate, but is DKA on the rise? And do you as clinicians, as healthcare practitioners, I know you guys are busy with all those things you're doing on a given day-by-day basis, but are you having proactive conversations surrounding DKA in your practice? Or even more specifically, are you teaching them, and what are you teaching them about ketones, and how are you monitoring ketones? So as we are presenting today, put in the chat what you're doing. Are you having conversations? Is it a top of line reminder? Because we know that this thing is deadly and it is preventable, right? Because I think we sometimes feel like we're held hostage by there. And so we want us to be mindful. We don't have a lot of ways to do ketones right now. We got to be ready because there is some advancement. So I'm going to open it up to the queens real quick because I want us to discuss a little bit about this lack of sensing. There was a survey developed to assess individuals living with diabetes of their current knowledge regarding DKA, and there was definitely an unmet need. The study was conducted in 6 Swiss and German endocrine outpatient clinics that specialize in the treatment of diabetes. And are you ready for this? 64% of individuals They don't test for ketones, right? They don't test for ketones. It's a really surprising number of that. They're unaware of that. So I'm going to shove it out to my queens because I've been prattling on so much this morning. So queens, tell me in your clinical practice how you are identifying it, addressing it, and reconciling it.
Well, I just want to say that I'm surprised you're surprised because, no, seriously. So we don't have numbers for the US, but I wouldn't be surprised if our numbers weren't higher than the 64% of individuals not testing for ketones. I don't think it's a common practice. I think we think we're pushing on, make sure your patient who's on insulin gets glucagon at home in case they have hypoglycemia. But I'm just not sure that everybody has that on their radar screen. In our clinic, if you're on insulin, we want you to have both something to treat hypoglycemia and the risk of DKA. So we talk about ketones. We talk about if you're sick, if you have a problem with your pump, if your blood sugars are really high and you've been correcting. I mean, we go through all of that. And we do ask people to get either urine ketone sticks or blood glucose monitor that can check for ketones. And I ask at every visit, and every visit I'm told the same thing. Oh, I didn't get them yet. And then the patient is in the middle of a crisis, and you're saying, okay, can you tell me what your ketones are? And they're like, well, I didn't get those strips. And so I think that our numbers might be even higher. And that mine's in an endo practice where we think about these things every single day. And I think that what happens is then I'm looking at this patient whose blood sugar has been 400 or 500 or whatever it is for a period of time. And I don't know what's going on. And I have to send them to the ER where if they had some strips at home and could say, oh, my blood sugar is elevated, but there's no ketosis, that's a different way of treating diabetes than if they're spilling large ketones.
Hey, Jen, in the chat, they talked about patient education, one of our listeners. Tell me about how you are being proactive with individuals, like what causes it? Are you figuring out why they're not testing it? So comment on that, please.
Yeah, and I also just want to comment, that's exactly what I was thinking, Davida, was we're not prescribing glucagon. Never mind having these conversations about ketones.
Right.
So it's, and we've talked about that before. So it's surprising to me. And remember, so I'm doing, diabetes cardiometabolic within primary care. And so I'm seeing probably a little bit different population than you're seeing, Davida. And so the conversation I am having sometimes is very shocking to me, where I'll even bring up ketones, about testing for ketones. And I'll get this blank look, like nobody has ever mentioned it before, if this is the first time I'm seeing someone. And so, we've been limited in the past over how, we always talk about our history and, how long we've been around and when we had to use urine testing, and then the evolution to being able to do blood testing. And it did change where you didn't have to use just a specific ketone monitor. There was dual monitors, but then that means you need providers to know which dual monitors. And if their insurance is only covering this specific glucometer, are they going to cover this glucometer that also does ketones? And so that is one conversation that I have to have. But the other conversation is I'm also seeing so many people with type 2 diabetes, and we use a lot of SGLT2 inhibitors. So a lot of the conversations I'm having is around triggers for DKA, because we're also concerned about euglycemic DKA in those populations, and also in type 1. But to have that conversation about if you have type 2 diabetes, which they are not, they're still at risk, but triggers for that. So if you're sick, if you're acutely ill, if you have the flu, if you have vomiting and diarrhea, how are we going to advise them on testing or stopping the SGLT2 inhibitor? if you're going in for surgery, you're going in for something, some stressor that can
Yeah.
trigger that DKA in that patient.
You
Are they
bring up a
going
good
to all go
point.
get
Go ahead.
stripped separately and do that separately? Exactly what you said, Davida. They didn't pick it up. They didn't go get it.
Well,
So are they understanding the value?
one of the things they say, though, too, my patients say to me all the time is, by the time I needed it, it was expired.
Yeah.
Mm,
And that's a big problem as well. But I also think if you look at the horizon, technology, technology, and more technology. So in type 1 diabetes, we have a ton of insulin pumps in our practice. And I think you see that across the country. But, one pump has now been approved for use in type 2 diabetes, and others will be approved. And that means those individuals are just on short acting insulin. And that puts them at a greater risk if there's a malfunction to the insulin pump as well.
Exactly. And that kind of brings that top of line discussion of what we call early detection. And we don't really have that opportunity for early detection. So I'm going to throw out there another kind of question for us to think about it. When DKA is not detected early, it can lead to hospitalizations. And many of us listening and watching probably treat a lot of these adults. I see some, comments coming in the chat, but let's just for a moment think about the annual average cost of a DKA hospitalization for a pediatric admission. So just think for a second. What do you think it is? So we've talked about, we don't get up the strips, they get expired, they have a cost associated it, but what is the cost of doing one DKA hospitalization? In terms of economic money, in terms of diabetes related costs, it's $21,000. Not only the effect of the quality of life and what we talked about, loss of life. I mean, that just absolutely breaks my heart. Okay, now you talked, Jen, about type 2 diabetes, and a lot of our listeners out there are not so top of mind with type 2 diabetes. But in this, I want to ask this question, true or false? I want you to be thinking about it. People with type 2 diabetes do not have issues with ketones or DKA. What do we think that is? I think we've kind of maybe said, oh, well, that was somebody who was misdiagnosed. And we know that, right? The queens have already talked in previous issues about misdiagnosis, but is this a true or false statement? Put it in the chat. Let's get that discussion going. And the reality is it's false. And we're actually seeing as the progression of type 2 diabetes goes, plus Jen's mention about SGLT2s, we actually see that lessening beta cell function. And then, of course, you throw steroids and other stressors on top of that. And we are seeing DKA associated with adults and pediatrics. Okay. Let's discuss another presentation. Our good friend Carol Weisham out here in the PNW, she did a presentation at EASD meeting this last September that showed that the average length of stay associated with DKA for type 2 diabetes is 2.7 days. And other studies have showed that 1 in 5 hospitalizations attribute to type 2 diabetes. So we know type 1s have it. Let's take a moment and discuss this real occurrence and this lack of knowledge in a population, as you said, Davida, are going to pumps. And then Jen, they're doing these other types of drugs that can, what I call, facilitate DKA. So let's kick that around a bit.
Well, I think what you have to remember too is that often a person who has type 2 diabetes has a bunch of other cardiovascular comorbidities.
Yeah.
And so if they get into trouble with DKA, which is very possible, it goes to say that their stay may in fact be longer for those individuals. But it also goes back to a lot of our conversations that we don't necessarily think of type 2 diabetes as the serious type of disease. And maybe that's part of the conversation. People out there, there's way more people, we know that, that have type 2 diabetes. And you've already pointed out that over time, beta cell function will go away, which sets that person up for DKA very much like our patients who have type 1 diabetes. Then you add exactly what you've talked in, comorbidities. Look what happened during COVID to these individuals.
Yeah.
And even now, I beg my patients to at least take vaccines for that because of their outcomes if they get COVID. But you're right, all their comorbids set them in a path for stress on their beta cell and whatever program they're taking. And some of these people are not yet on insulin and maybe need to be, because we know there's delay in starting these individuals with insulin as well. So I think we need to rethink the whole concept of DKA in type 2 diabetes, because I think the numbers are there.
Yeah. Hey, Jen, talk about SGLT2s and how that mechanism is, and how, what's that perfect scenario, and how do we need to be mindful of that?
So this discussion made me just think of a patient that we had. This was a couple of years ago. So when we think about people with type 2 diabetes, the issue is when their insulin, they don't have enough insulin, right? So this is when they're at risk. So I actually had a patient who, remembering burden and diabetes distress, that we're asking them to do more and more for something like that. And I had this lady who really was insulin deficient, needed to have some insulin, but she really just was quite resistant about it. And I had the conversation. I had the conversation with her quite a few times. And what happened was she got a tooth infection, a really severe tooth infection. But she ended up in the hospital for almost a week in DKA, where, her A1C was 7.5 to 8, but she was on an SGLT2 inhibitor. She was insulin deficient, needed to add some insulin, was resistant, kept, I'm going to change. I'm going to do this. I'll do this instead. But now suddenly she's discharged on not an optimal regimen of NPH and regular insulin. And now she's reaching out to me. Can you help me? Can you change my insulin? And so all that was a tooth infection that pushed her over, and was a whole week of hospitalization. So we definitely have to have these conversations for prevention. But again, what you brought up, Davida, is sometimes it's too late now. If you're checking with a keto meter, right? Something that can check that way. Either the strips are now expired because the shelf life is shorter. Right. And at this point, now they're in trouble. So talking about future technology, it's wonderful to be able to have something that is telling, because also in the setting of euglycemia or your blood sugars, that you don't expect somebody with type 2 diabetes who has blood sugars at 200 or 180 to necessarily have DKA. You're not necessarily thinking about that. But if we had something that would be able to tell us, hey, this is what's happening, then you need to either call your provider or have a plan in place.
Well, you have a great segue, because I'm going to transition to that specific ketone bodies we're looking at and how we can monitor them. So we have that question. So there are 3 ketone bodies, and we have ways to monitor each of them. And so I want us to think presently, what is available for checking ketones at home? Is it A, urine ketone testing only, B, ketone meters and strips, or A and B? So put in the chat. I love that everybody's talking about just really getting our juices going with this. So which one is it? What do we currently have presently available? And that is currently we have talked about it. See, yes, our listeners are they're tracking with us. We have the ability to check urinary ketones, and we have the ability to do ketone testing with strips. But many of our listeners are talking about, we've got to make sure they're not expired. But in addition, those urine testings are acetoacetate, and those ketone testing is better. But why do we need to look at beta hydroxybutyrate? We've talked about early indication. So Queens, let's transition to the horizon, what's coming. It's not here yet, but we are seeing it, we're knowing it, we're hoping 2026. And that is this discussion of continuous ketone monitoring, not point of care, not just finger or urine, but continuous ketone monitoring. Davida, talk to us about this.
Well, it is very exciting. I would just comment before I jump in that I don't think, and I hope after this, people will think more about ketone testing for people who have type 2 diabetes. Just like CDM, we need to also do this. But continued glucose monitoring is checking for ketones, not ketoacidosis. And just like CGM measures glucose in real time, it continuously measures ketones in a real time, glucose and also ketone monitoring. So think of a sensor that you could wear that could be great for people with diabetes, and they could easily identify when that rise in the ketones started. So and then you could see, and you could make decisions based on, well, I'm seeing this. Well, let me talk to you about what can we do to get rid of those ketones? Is it, fasting ketones? Is it you're really sick and you need extra insulin? There's, a bunch of things that you could use those ketones for, but it would be one sensor that would give you glucose and would also give you ketones, which I think is amazing. So it's currently under development. Fingers crossed we'll have it fairly soon. It's evidence-based on a 2021 proof of concept, a feasibility kind of study that showed a CKM sensor could continuously monitor ketones, and the patient population were healthy volunteers who were on low carbohydrate ketogenic diets. And when the FDA looked at all of the data and some of the research, they gave it this special classification that will move it forward sooner. So, we have to watch for it, but just think about that. Patients don't have the strips at home. They don't want to poke their fingers because they're already on a sensor. They don't want to get an extra meter. But if we had a sensor that could tell us both and would have alarms for glucose, but other alarms for ketones, and then you could look at the whole picture and say, okay, we can treat you at home, or please go to the ER because we really want to prevent the DKA.
Yeah.
Think how special that is with
my
people
mind
at
is
risk.
blown about this, Jen. Talk about the future.
Yeah, I think it's special when we're thinking about the people at risk, and the pharmacist in me has to come up with, when we give people other drugs. You brought up steroids, earlier. That's when we see everyone needing insulin adjustments or the addition of insulin, people getting chemotherapy and other things that put them at risk. Plus, I mean, everyone with type 1 diabetes, clearly.
Absolutely.
Anyone with type 2 diabetes who's insulin deficient, for sure. But it's those special circumstances that put people at risk, especially important, especially that it's two, all in one. We're not burdening anybody with anything additional. Go get this meter, go get this strips, do more.
I don't know how many times a week you get a call that says, I'm on an insulin pump, whether it's type 1 or type 2. And my blood sugars have been running in the 400s for the last 3 hours. I've changed my site. I've taken an injection away from the pump, all the things we teach people to do. And my next question is, have you checked for ketones? Now, if I have ketones, I can make a much better decision and a safe decision for that person with diabetes. If I don't have ketones, sometimes I have to send someone to an ER when I really want to treat them at home because I don't want anything bad to happen. So I'm so excited about this opportunity, really excited.
I'm so excited too, because I think ketosis is a fairly uncharted territory. It reminds me of when we first got to CGM years ago, when we were always doing point of care glucoses and we're trying to make meaning of them. But imagine we are barely checking ketones to begin with. And now we're going to jump to this continuous ketone data. So I think it's pretty imperative for us to keep a bit of an open mind find because we don't know what we're going to find.
Right.
Not that it's a bad thing. I think we're actually going to reveal there are people that are ketosis prone more than other people. There are scenarios, there are circumstances. And so I kind of want to change as we start to wrap up to go, okay, now let's be very specific. Let's talk about ketones and pumping, because at the ATTD meeting this last March in 2024, Dr. Jennifer Shear presented a study evaluating what happens to beta hydroxybutyrate levels in relationship to elevated levels on a continuous glucose pump, continuous insulin infusion pump, where it was suspended in those with type 1 diabetes. And some of them, the ketones started in 30 minutes. 30 minutes. Some of them, it took forever. And I'm not saying we got to know those things, because really we are blinded and uneducated about this, even though this is a deadly combination. So let's kind of, as we wrap up in the next few minutes, talk about how this opportunity for knowledge regarding this condition is going to really, it's like this new stuff. That's what I'm so excited about, because I don't think we know ketosis. And now we get to peer into this new area of diabetes.
So, you know what what surprised me about Dr. Scher's study, and of course, she's a wonderful pediatric person at Yale, and I love following her work. But what surprised me was we tell people it's okay to disconnect for short periods of time from their insulin pump, to take a shower, to do whatever. And if you still had your sensor on, presumably that would tell you, wait, you've been off that pump too long, or remind the patient to get back connected. And perhaps when we figured out who was ketone prone, we might be able to find a solution for that. It's like, it's like we've almost been practicing with our one arm tied behind our backs. And blindfolded. And so now we're going to get these opportunities. And I feel like it's like a puzzle we're putting together. And how many years when we first started looking at CGM and AGP, and we thought, oh, now integrated pumps. And we're like, oh my gosh, how could we live without any of this? And now I'm starting to think, how am I going to live without this? Give it to me now. So I'm really excited about her data. And I think you're right. We're going to learn more than we thought we ever knew, or was out there to learn, once we get these type of sensors on patients. And then we won't have to worry about go find a strip, go find a meter. It'll be embedded in the sensor you're wearing. And you can tell me all that data, or I'll be able to go up in the cloud and see all that data.
And Jen, talk about what the pumps might do with that data.
I was just thinking that. I was just thinking, when you think about the algorithms that are potentially can occur with now putting that amount of data in. So when we think about people with ketones, where exercise is an issue, where it might be counterintuitive to be using less insulin or more insulin, but they actually need more carbohydrates. But by identifying the ketones early, to have that integrate into insulin pumps, and even if they're not on insulin pumps, to know what to do. Well, then I actually need carbohydrates, or I actually need insulin and carbohydrates. So it's that early identification is going to be spectacular. The advancement in technology is amazing.
Might I add diabetes and pregnancy?
Yes.
Yes, we didn't talk about that. Oh my God. It's such a big increased risk. I mean, we just saw a recent patient, and I just think about, it's like we've caught up with the person with diabetes, and now we're going to be ahead of them. And that's what just warms my heart so much. And that's how we equip the person to have diabetes rather than it having them. Sure. And that's what's so innovative about it. Yes, it's about cost and quality of life, but it's about empowerment. And I think that's what we're here about. That's why us queens get together every month, and we're excited and we're encouraged, because we feel so excited about empowering our patients to live with this disease, taking it along for the ride of their life. Girls, we discussed a lot today. We're kind of coming to the end of our conversation. Please put your questions in the chat. We want to make sure that this is interactive for you. We'd like to remind you that all of our previous queens things have been out there. You can go back and look at it. Please subscribe. Please hit that QR code. We want you to earn that free CME credit. To claim your credit, you can scan that QR code or visit this link. And as we wrap it up, we're going to make a really quick discussion. Kadir said, is it possible to have ketone positive in HHS? And by definition, HHS isn't a DKA. But how about this? We don't know a lot. We're going to figure it out. And so I think that's what's so amazing about this. And from us three queens, I know I can say we love you. Happy holidays. Be safe. And we'll see you in 2025.